Hi, it's Dr. Centeno, and thanks for joining us here at You've Got the Power. I'm going to focus today on just a follow-up of a topic that I introduced on Friday, and that is doing some bigger deep dive research into Kratom, Kratom, and how that may impact orthobiologic procedures like PRP, bone marrow concentrate, etc., or quote stem cell procedures, and looking at that both from the standpoint of what is this stuff, how does it impact potentially things like anesthesia, how does it impact potentially things like how those orthobiologic injection procedures are effective or not, or work or not. Now, there's a lot that we don't know because this is a relatively new concept that we're all dealing with here. But I wanted to go through that. Again, I'll have a short presentation, and then that short presentation will go to Q&A, whether it's about that topic or any topic at all. Again, for those just joining us, we're taking a look at Kratom. What is it? What are the implications of taking it with some of these orthobiologic procedures, PRP, stem cells, etc. So let me go to that. And let me share my screen here. And then we'll go to Kratom here. So again, we're talking today about how does Kratom impact orthobiologic injection procedures, PRP stem cells. What is this stuff? What should you know about it? Does it have an impact? Does it not have an impact? Do you have to come off of it prior to these procedures? Can you take it with these procedures? All of that good stuff. Now, Kratom is just the most recent of sort of a long list of what I call Facebook sold stuff or social media sold stuff. You know, I've done these presentations on things like BPC 157 and other peptides. Kratom is another one you can find sold online. You can also find it in gas stations. And I tend to do these deep dives when I start to see this interfering with patient care. Kratom is not something that's on the list of really 99.99% of the doctors. They may have heard of it as hillbilly heroin sold in truck stops, but outside of that, they really have no position on it or don't know a lot about it. And it's not easy for physicians these days to keep up with all of that stuff. So, you know, what I'm trying to do here is to keep up with all of that stuff, because this just became an issue with some of the patients that we see. So Kratom is made from an Asian evergreen plant, made from the leaves of that plant. It has its biggest active substance is mitragynine. It's a difficult word to pronounce. I can't say that I'm any better at pronouncing it than probably my patients are. That substance and its metabolite act at the opioid receptors, mu, delta, kappa, and that's where narcotics also act. Given the existing information we have from animal models, the receptor action at those narcotic receptors is probably less than opioids like prescription narcotics. Having said that, some of the human data might argue otherwise, but there probably is less action on those narcotic receptors than something like fentanyl. So the first question is, if it's operating at a narcotic receptor, is it addictive? Well, yeah, anything that acts at narcotic receptors is addictive. A good example of a weaker narcotic receptor would be some of the synthetic, quote, non-narcotic medications that are out there, like Ultram. They operate at narcotic receptors, and as a result, there is some addiction potential. In a 2014 study out of Malaysia, where bars are serving this kratom-laced tea, they reported on almost 300 users, and more than half of the regular users developed severe dependence problems, and 45% showed moderate kratom dependence. So they actually saw withdrawal symptoms when these patients tried to go off of this stuff. So yeah, it seems to be addictive. Now, one of the big things that we get concerned about is the interaction of these sorts of drugs, kratom, THC, low-dose naltrexone, narcotics, etc., with anesthesia, because they can cause the need for massive amounts of anesthesia during a surgical procedure. So any drug that acts at a narcotic receptor will dramatically increase the amount of anesthesia you require to stay asleep. And it creates what I call a tightrope patient. You've given the patient what should be a lethal dose of anesthesia drugs, like, let's say, fentanyl, Versed, propofol, but they're still talking to you. And if you give them enough to put them asleep, then that could be enough to depress their respiratory drive. So they're having a hard time breathing, and they're having to increase the oxygen, manage their airway, turn off the medication, let them come light. So you're in this tightrope scenario with these patients, where the patient is either awake and talking with you, or they are sound asleep and so obtunded that they start to lose their oxygen saturation. So just realize that you can stay on any of these drugs. It just increases the risk of getting injured by the anesthesia because of the extremely high doses it will require for you to stay asleep. And in addition to that, you've got the risk the doctor can't complete the procedure. So that, just like with PICL procedure, we had a patient this last week taking Kratom, hard time getting this person asleep, hard time keeping this person asleep. The good news is we got about 90% of the procedure done. The only thing we couldn't do was the injection in the front at the anterior longitudinal ligament, because the patient was moving around too much and there was too high a risk of sticking the needle into the internal carotid artery, internal jugular vein, phrenic nerve, etc. That wouldn't be there if the patient was able to stay still and was completely knocked out and unable to keep their oxygen saturation. Another big potential concern for kratom is its action at the COX-2 pathway. So, we have predictable ways in which we respond to, our bodies respond to injury. Our bodies respond to injury, number one, with acute inflammation. And that acute inflammation is how we heal. So the body has chemical pathways, including cyclooxygenase 1 and 2, that are activated in order to get that healing drive going. And the problem is that when we block that by using prescription and over-the-counter non-steroidal anti-inflammatory drugs like Celebrex, which blocks COX-2, we can also block that healing cascade. So we know that COX-2 is critical for tendon, bone, and bone healing. We also know that it's critical for mesenchymal stem cells, like the stem cells that would be found in bone marrow concentrate, to do what they do, to proliferate, migrate, and differentiate. So if you're blocking COX-2, you're probably not doing yourself any favors on trying to heal after one of these procedures, whether that procedure be a PRP procedure or a bone marrow concentrate or other procedure that involves mesenchymal stem cells. So in conclusion, kratom is an addictive narcotic-like drug that can be fatal in large doses. I didn't bring up that we've now seen a number of different lawsuits from the families of kratom users who were killed by the drug, going after some of these online companies that sell it, with some pretty successful jury verdicts at this point. It's also banned in 5 states. It's restricted in 12 states. This drug increases the anesthesia requirements like all narcotic acting drugs do. It also blocks an important part of the healing cascade. Hence, the recommendation is just to avoid this drug. However, if you are already on it, then you should probably wean off of it. And that may need to be medically managed because you may get withdrawal symptoms just like you would in trying to come off of Percocet if you were taking that on an ongoing basis, or Norco or Vicodin or any of those. And how long you should be off of it is not really known at this point. I'm going to say for at least several weeks and likely several months in order to reset those systems that we were talking about. It's probably on the order of 1 to 2 weeks in order to reset that COX system on the healing side, and probably several months if we're talking about you no longer requiring extremely high levels of narcotics and other anesthesia drugs to stay asleep. Okay, well, let's see if we have any questions here. I'm going to stop all of that. Looks like we do. So we got a bunch of them. Centeno-Schultz has been advanced by Daniel Wren. There's a limit to the number of times posterior PRP injections to be performed if there's a small improvement each time. Not really. I mean, practically, yes. You get into the point where, is it appropriate to do 12 treatments, 6 treatments, 4 treatments, etc.? And there's some risk-benefit analysis there. But as far as doing posterior treatments, as long as the patient is demonstrating iterative improvement that we can sink our teeth into each time, then we'll generally go ahead and continue. Okay, yeah. So Melody, we got lots and lots and lots and lots and lots of stuff on Kratom. I don't want to engage too much. So again, Melody, we're not talking about addiction from the standpoint of coffee or chocolate activating a psychological addiction, or in the case of caffeine, a physical addiction. We're talking about a compound that's operating at narcotic receptors. So I'm going to skip over all of this stuff because we're kind of moving away from a productive conversation there into some sort of lecture being given by a patient to a board-certified physician. Duck P, when trying to strengthen the suboccipital muscle, should we train them with low load, high reps to minimize action of superficial head extensors, rotators? Yeah, so Duck P, we have, I think as you know, we have small movement type suboccipital muscle exercises that you can do. The focus there is low load and initially low range of motion, with range of motion increasing as you go through that program. Mark, I have instability from C5 through T4. Could this instability be responsible for the problems I'm having with holding my atlas and occiput adjustments? Could be, it's possible. Usually we're talking about upper cervical instability there, but lower cervical instability can influence the upper cervical spine. It's been advanced by Sherry Scott. Are there other medications or supplements that we should avoid before procedures? Yeah, as I've said before, Sherry, non-steroidal anti-inflammatory drugs are a big one. For the same reason you'd want to stay off Kratom. Any inhibition of the COX-1 or COX-2 pathway is not a great idea. In addition to that, obviously narcotics are another one. We talked a little bit about that today. THC is another one. Also be cautious with the CBD type drugs and their derivatives. More from the standpoint with those two of increasing needs for narcotics and other drugs during anesthesia. and difficulty in recovery after a procedure. And then low-dose naltrexone is also on that list. So there's a list of things that are hard contraindications, like staying off of steroid drugs, corticosteroid drugs, or staying off of non-steroidal anti-inflammatory drugs. And then there's the relative contraindications of things like THC, Kratom, etc., where it just increases the risk for bad things happening during anesthesia and increases the risk for the doctor not being able to get the procedure done, and then the risk for having a very, very rough recovery. Doc P, any chance you can make a topic on muscle stability and proprioception, how they can play a role in CCI? Yeah, that sounds like a great topic. We'll do that. Avoiding Melody right now here. Caleb, I know the prevalence of CCI in EDS population is roughly 1 in 15. Do you think this is lower in male EDS population, perhaps like 1 in 25? Yeah, I think it's safe to say that women have a higher propensity towards EDS than men. It's been advanced by Gerald Stoneman. If you already have been taking Kratom and has been a pretty good job of dealing with your pain, how long before a procedure should you need to stop taking it? Yeah, Gerald, as I said, I think at the very least several weeks and probably several months. Several weeks would be for its COX-2 inhibition. Several months because it's actively, like all medications that work at narcotic receptors, causing you to need very, very, very high levels of medications. Caleb, what do you use to target the upper facets, capsules, nuchal, PAOM, and EDS? You mentioned how dextrose is better than PRP and EDS, plate lysate plus dextrose. So in EDS patients, in general, they tend to do better with dextrose prolotherapy than PRP, and they tend to do better with bone marrow than both. So if we can use bone marrow, that's usually a good choice. If we're just trying to stick with platelet-based procedures, then we can combine platelet lysate and dextrose. Yeah, Melody and Cami, we are going to block you. So I'm going to ask my folks here to block you when we get a chance here, because you're just throwing stuff out there as Kratom advocates. I get it. It may work for you. It's a narcotic drug, no different than Percocet. It's a weaker narcotic agonist than something like oxycodone. Having said that, it's still fatal in large doses. It's still addictive in the same way that Ultram has both of those properties as well. Jim, can you treat the ligaments that stabilize the SI joints with just ultrasound? What ligaments would these be? Can dextrose be enough if it's moderate in severity? Sure, Jim. Yes. Those can be done easily with ultrasound. Now, it's very hard to get intra-articular inside the joint. So if you wanted to get inside the joint, you would need to use X-ray guidance with contrast confirmation. But if all you're trying to do is to strengthen those ligaments, then ultrasound is just fine for that purpose. Those would generally be the short and long dorsal SI joint ligaments. If you've got a more mild to moderate problem, dextrose can be quite effective. It just takes more numbers of treatments to do that. Ulysses, is prolozone effective for cervical instability like lower neck? We don't use prolozone. There's less data available on prolozone, but my overall sense of it would be that it would be about as effective as prolotherapy for lower cervical instability. We published a paper about 20 years ago on that topic that showed that lower cervical prolotherapy was very effective for treating translational cervical instability in the lower neck. Daniel, what is causing throbbing headache? Who increases or that increases with the pulse rate is that POTS. In general, that could be related to intracranial hypertension. That could be related to other things as well. But I would say that if you have a throbbing headache that is coincident with your pulse rate, that one option would be intracranial hypertension or just decreased backflow of the cerebrospinal fluid out of the brain. Because if you look at, for instance, the spinal cord under ultrasound of the upper cervical spine, you will see very, very clearly that it mirrors the pulse rate. So that can sometimes be a dural headache. Jim, I know you support upper cervical chiropractic, but doesn't every patient that goes to an upper cervical chiropractor get a diagnosis of subluxation? Where do you draw the line? Jim, we have patients that swear by upper cervical chiropractic. The concept of realigning the upper cervical spine makes sense to me. As far as the business model of just chiropractic in general, finding a subluxation, I don't disagree with you at some level, but I can't ignore the fact that 60%, maybe 70% of times of my CCI population do really, really well with upper cervical chiropractic. Stevie Hutter, if tramadol, which is the same here as the US Ultram, affects the healing pathway that you mentioned. Stevie, I haven't done a bunch of research on that. At some point, I'd be happy to do that. Cami, that's actually not factually accurate. There's been 2 kratom deaths, both of whom went to court, both of whom ended up in a situation where many, many millions of dollars were awarded to these families because kratom was the sole cause of death. Edward, can you envision a scenario in which looking down at books all day could damage the transverse ligament in a non-EDS patient? I can't, not unless that patient was old. Now, we certainly know that older patients over time can develop degenerative changes in the upper cervical spine. And anytime you develop degenerative changes, you can certainly see issues with laxity in a ligament. So, but in a young patient, harder to see. Edward, is it dangerous to use infrared heating pad at the skull brain? No, shouldn't be dangerous. Vivan, if you want to get a 3D view of my dens, what view would you need to ask my GP for? I think my dens is rubbing on my C1. There's an intention on the right side. My C2 translate bilaterally 14 millimeters. We generally wouldn't use a 3D view of your dens. We would use a movement-based view if we're looking for instability. So that would be digital motion X-ray, in a pinch, rotational CT, although rotational CT isn't as sensitive for issues as DMX, or we could use a movement-based MRI. Jim, do you agree that orthopedics pick and choose what ligaments they view on a spectrum? They will rarely operate on an ACL if it's not torn, but readily operate on a lax ankle without signs of tear. I think what you're bringing up, Jim, is the difference in diagnosis there. So, for example, for an ankle, there are stress ankle views where we can actually see something moving too much, very similar to a digital motion X-ray in the neck. So that's why you end up getting ankle surgeries where the ligament may look fine on MRI, but it's functionally not doing its job. ACLs are a different story. We really don't have that same kind of stress imaging. So it really relies on the doctor's physical exam. And physical exam, especially in orthopedic practices, has been further and further marginalized. And as doctors are forced to see many, many more patients in order to make the same amount of income, it gets more and more marginalized, so it just doesn't get done. Vivan, concerned I have a structural issue as there is a hole going through the entire bone at the base of the dens. Also looks like the bone is gone at the posterior as well. So I need to take a look at the images to get a better sense of what it is you're talking about there. Strange. Dr. C, is it better to drink, eat something cold or warm, drinks food after a PICL? No preference there, whichever is more comfortable for you. Ulysses, do you recommend people take collagen supplements to help ligaments and tendons and joints, especially osteoarthritis? Not so much collagen supplements, but I think we've got better data, Ulysses, on things like glucosamine, chondroitin, and MSM. Those seem to have an anti-inflammatory effect that withstands randomized controlled trials. Jim, would you recommend Dr. Otona Silva for SI joint stability in Washington area, or Dr. Jason Adamman who uses P2G as his prolotherapy solution? Either one would be fine. We trained Dr. Silva here in Colorado, so he'd be a good choice. Dr. Adamman's been doing regenerative medicine stuff for a long time, so he'd be a good choice. So it's really personal preference there. Ulysses, what does moderate lordosis mean on an x-ray? It just means moderate curvature in the spine. Stevie, is it possible that upper cervical injections alone can repair ligaments enough so the ligaments eventually can pull your cervical spine back into alignment? Or is it more likely that chiropractic care would be needed too? I think we've seen both, but if upper cervical chiropractic is working, then we generally don't, or we generally just continue it. And if it's not working, or if someone hasn't tried upper cervical chiropractic, it's not required as a result of the procedure. So we see patients who don't have upper cervical chiropractic who do just fine, probably through the mechanism you're describing. And we have patients who swear by it, where we really think it probably helps them. Mark, your take on risk with Flexeril, methocarbamol, Lyrica usage for flare-ups. Again, Mark, any prescription medication that you're using can increase the amount of narcotics and other drugs that you require either during the procedure or after procedure. Those would tend to be lower risk than drugs that work directly at narcotic receptors. That would include drugs like narcotics, like tramadol, like the Kratom that we've discussed, and drugs that can also mess with some of those receptors, like THC and low-dose naltrexone. Ulysses, the doctors that Jim mentioned have treated CCI patients for, and I'm not saying they're top ones. Yeah, Ulysses, we don't recommend CCI treatment outside of Colorado. Jim, when treating ligaments with PRP, how does it behave when injected? Does it spread across the ligament, or does it stay localized right where it is injected? In general, Jim, it spreads across the ligament. Okay, any other questions for me? Today we focused on how Kratom is likely impacting interventional orthobiologics procedures. Got a question from Vivan here. What about upright CT, cone beam CT? My DMX is hard to view, DENS or structural vestibular scoliosis. Yeah, Vivan, we don't use upright cone beam CT for diagnosis of CCI at this point. So again, getting back to the discussion, we discussed the use of Kratom today. We don't recommend its use with these procedures. It's not an absolute contraindication with these procedures in that it's going to make anesthesia much, much harder. Now, just realize that we have some information that it can mess with the COX-2 receptor. And so it may be interfering with healing, but we don't have a ton of research on that. And there isn't a ton of research on Kratom in general. meaning that we have a tiny, tiny fraction of research on kratom compared to other drugs like THC at this point. So the literature base is still evolving, but I can tell you that it's likely addictive. It is operating at those narcotic receptors, and consequently, it's got implications for patients that use it with regard to the orthobiologic procedures we discuss here. John, does the shape of the C0C joint have a protective effect on the alar ligaments? Yeah, John, if you look at that typing I put together, a type 1C would be a shallow C0C1 joint, and that can have an impact on alar ligaments. So meaning that when the C0C1 joint is deep, a deep ball and socket, then that's going to protect those upper cervical ligaments. Or take load off of those upper cervical ligaments. When it's shallow, as discussed in that type 1C instability, it's going to put more stress on those ligaments. By then, my face is going numb when I wake up, and posterior neck, no neuropathy, muscle loss as of yet, not trigeminal, V2 pattern. Yeah, by then that can be related to upper cervical instability. Obviously, it can be related to other things as well. Ulysses, the muscles at the skull go into spasms to help the C1-C2 joint. I think, yes, that's a reasonable assumption that you can see muscular spasm when there's C1-C2 instability. Any other questions I can answer out there? Again, today we discussed the use of kratom with these procedures. We don't advise its use, and we advise patients to get off of it prior to these procedures. I sort of put this in the list of all of this stuff being sold online, which really isn't controlled in any way, shape, or form. And that, we doctors struggle to keep up with because, we start to experience patients who use these things, and we're like, why was this guy very, very different? Why couldn't we put this particular woman to sleep? She's not on any drugs that we would expect. And then we ask her after the fact, and after receiving a 3x fatal dose of medications and barely being able to go to sleep, we realize that a drug like kratom is involved, or prior. We realize that the patient is taking massive amounts of THC, etc. Caleb, have you ever had any EDS patients who had upper cervical instability not involving ligaments in front of the spinal cord, alar transverse, who did well with PRP, the C0, C2 facets, nuchal? Yeah, Caleb, if you look at some of the prior stuff that I've put out there, you'll see that the type 3 instabilities, type 3A, type 3B, type 3C, of those type 3A, when there's instability in flexion at C2-3, does quite well with posterior injections. So take a look at that because I think that will answer your questions. Krishna, if type 1C instability, will any additional treatments or PICL can help? Yeah, the only way that we would recommend, Krishna, that get treated is by tightening down those upper cervical ligaments. We obviously can't change the shape of the 0-1 joint, nor would it make any sense to try to surgically change that shape or do a fusion if we can treat you without fusion. Daniel, I have CCI, so maybe the throbbing headache is from blocked CSF flow from a misaligned atlas. Certainly that could be. Other questions I can answer about either today's topic, which was kratom and orthobiologics, or any other question about anything else today. Vivan, my dens is a large flat surface, like cutting off a carrot at the top at an angle. Would the alar be gone then? Carol thought it was hitting bone and wore it flat. Hard to say what instability would be involved with what you're describing. Caleb, do most EDS patients have a shallow C0, C1 joint? No, not based on my experience. It doesn't really seem to be linked to EDS, more just the way the person was born, or what we call congenital. Any other questions that I can answer out there? Again, to wrap up what we were talking about today, the topic was using Kratom and orthobiologic procedures. The goal is to get patients off of Kratom for a bunch of different reasons that we discuss. And again, it has the potential for blocking COX-2, which blocks healing. And it also obviously has the potential to act at narcotic receptors, which can create other problems with anesthesia, post-op recovery, etc. I think I will be here this Friday, and I thought we had a really good topic that someone brought up before we got all into the Kratom crazies. Let's see here. We had a good topic that someone brought up here. Yeah, muscle stability, proprioception, and how they can play a role in CCI. So, Doc, I think I'll try to do that. I really like that topic. So I think I'll try to do that for this coming Friday, how the upper cervical muscles are involved in neck proprioception, why they're important, why they're different than other muscles, and how that plays into upper cervical instability. So that sounds like a great topic. I appreciate you bringing that up. Okay, guys, have a great week, and I will see you this coming Friday, and we'll go from there. Thank you.